Hey everybody, my name is Sarah Kreger. I am an emergency physician and intensivist at UCLA, and this is ICU EDU. Today we are talking about one of my favorite topics in the whole world, which is the right ventricle. Now, whenever I give a lecture on the right ventricle, I feel the need to start by talking about why you in fact do care about right ventricular physiology. Because for very understandable reasons, many of you probably don't care particularly right this second, but you maybe should. So let's talk about what I like to call my regularly scheduled ICU admission. Happens a couple times a year. Let's say we have this 34-year-old female. No medical history, but she comes into the emergency department with shortness of breath after getting off a flight from Thailand. Blood pressure's, kind of fine, 103/77. Heart rate's in the 140s though. Respiratory rate's in the 30s, and she's not satting great. She's satting like 93, 94. Now, this is not a mystery diagnosis. You send her to the CT scanner, and she has a pretty solid pulmonary embolism. And while she's in the CT scanner, her blood pressure drops to 76/40. So, hypotensive, what are you going to do? You give her a 2-liter IV fluid bolus. Unfortunately, after you do that, she doesn't look so good. She, in fact, is now kind of getting a D+ on the eyeball test. She's more tachypnic. She can't breathe. She's saying, I don't know, sit me up. I don't feel good. And her SATs are not getting so good either. So what do? You intubate her. Well, when you do that, she goes into a cardiac arrest, which is how we end up with my regularly scheduled ICU admission. Now, here's the thing. This didn't have to happen this way. I actually call this sequence of events a physiology epic fail. Because if you have a good understanding of right ventricular physiology, it didn't necessarily have to happen this way. Now, you may be thinking to yourself right now, how many times a year do I actually see patients with a massive PE? And that's true. It's not that common. But right ventricular failure itself is actually not nearly as rare as you think. It's not just like, if you kind of cross your fingers that you won't be the person who's on the day that the patient with the Remodulin pump comes in. I mean, that's great, but you're still kind of out of luck because it's truly not that rare. So, for example, do you see the occasional sepsis patient? Sepsis every now and then? Well, yeah. So this was a study, and it was a meta-analysis of 1,300 patients looking at the impact of right ventricular dysfunction on septic and septic shock patients. So what they did is they looked at all these patients, and what they found is that of these sepsis and septic shock patients, a third of them had RV dysfunction. Now, does that matter? Well, it turns out it did, because RV dysfunction was associated with increased mortality in these patients. And I actually find that particularly interesting because consistently what we found in the similar literature is that patients with LV dysfunction, you see it a lot in septic shock, right? Sepsis-associated cardiomyopathy, you get LV dysfunction, but LV dysfunction actually hasn't been consistently associated with mortality in these patients, but RV dysfunction has. What about ARDS? You see the occasional ARDS patient? Probably. So this, again, meta-analysis, 1,800 patients with ARDS. What they found was 20% of them had RV dysfunction. And again, it was clinically significant because it was associated with increased mortality. Heart failure. Ever see a heart failure patient comes into your ED sometimes? Probably yes. So this was another meta-analysis. 4,700 patients looking at chronic left-sided heart failure. And what they found is that almost half of those patients had right-sided dysfunction as well. And again, starting to see a trend, that was associated with increased mortality. COVID, we've all seen a handful of COVID patients in the recent past. So this was a meta-analysis of 3,800 hospitalized COVID patients, not necessarily in the ICU, but hospitalized. What they found was that 20% of them had RV dysfunction. And again, the trend, it was clinically significant. It was associated with increased mortality. What about meth? Now, depending where you live in the world and in the country, you may see more or less meth. But I see a patient population where we have a lot of meth going on. And this, to me, was really interesting. So this was a registry study. And so this was an analysis of the Pulmonary Hypertension Association registry data. And they found something very interesting. What they found is that more than 20% of those patients in this sort of general registry, not targeted towards meth users, just general pulmonary hypertension, 20% of these people had methamphetamine-associated pulmonary hypertension. And of those patients, the meth-associated pulmonary hypertension patients were more likely to be the people that you see in the ED and that are hospitalized. And, I think this is very interesting, partially because this is probably a dramatic underestimation. I mean, it seems enormously likely to me that meth-associated pulmonary hypertension are exactly the same patients who are least likely to end up as part of a registry. And so I think that we're probably underdiagnosing it. Now, we don't know what percentage of meth users develop pulmonary hypertension, but increasingly to me, meth is a risk factor that I need to think about. So I could keep going with this, but hopefully, at least by this point, I've convinced you that you care about right ventricular physiology. But there's another reason you care. And it's one of those things that this is where our true job is as resuscitationists. These conditions that are high risk, but rescuable. Because there's certain things that we can't do anything about, massive head bleeds, very high risk, but I can't necessarily fix this patient. What I do may not make the difference between this patient sort of arresting and dying and this patient walking out of the hospital and going back to their life. But pulmonary hypertension and RV failure, we can make that difference. These patients are super sick, but if we know what we're doing and do our job right, we can get them out of the hospital. We can make them better. So let's discuss. We're going to organize this talk into 4 parts. The first part, we're going to talk about the physiology of RV failure. Then we're going to talk about RV failure diagnosis and differential diagnosis. We're going to then talk about how this applies clinically and the RV spiral of death and what that looks like at the bedside. And finally, we're going to talk about management.